My name is Ike Ahmed from Canada and United States. With me I have Gok from the UK, and we have Rob from the United States as well. And all three of us are hoping to share with you some of our perspectives with regards to ECP. And just getting the idea about everybody here. How many of you are familiar with the concept of endocyclophotocoagulation? How many are familiar with it? Anybody using ECP? Okay. And others are kind of interested in hearing what it's about and what's the deal with ECP. So maybe let's just start off, because I know it's still, not, even though ECP's been around for a long time, almost as long as Rob has been around for.
Almost. I started when I was 4.
It's still, I think, I think needs a lot more discussion and understanding. So maybe we can start. Maybe I don't know if Goku, you want to start off just telling the group, like, what exactly is ECP? How do you do it? What exactly is it? Before we get into more details.
Okay, so ECP is essentially a diode laser, but it's not through the sclera. It's with direct visualization. So you have a probe, and in that probe you have a light source, xenon light source. You have a camera, fiber optic camera or digital camera, and then you have a laser, 810 nanometer diode laser. And you basically ablate the ciliary processes to reduce aqueous production, primarily by treating the melanin on the ciliary body epithelium. And as a result, you get the reduced aqueous outflow, but it's a direct visualization, so you can see exactly what's going on to the ciliary process at each time. And the energy settings that you need to use are a fraction of what you would do with transscleral. So 250 milliwatts would be your sort of standard setting, whereas with transscleral you're sort of starting at least 6 times that amount. So that's it sort of in a nutshell, I guess.
Yeah, I don't know if you probably have a video showing later on. I don't know if we're going to show the video here, but Rob, if we would have introduced like an endoscope with a light source and a laser in 2022, I think we got a lot of excitement. Don't you think so? Endoscopic surgery. Right? But you've had a lot of experience with this. What do you think the technology brings to you that you wouldn't get with other technologies?
Well, I think it brings, like you kind of alluded to, I think it does a lot. So it's an endoscope, and it's the only way sometimes to see stuff in the eye, especially in the posterior chamber. Mm-hmm. So we classically talk about using it to lower IOP, laser ciliary processes. But we also there's a secondary group of things we do is just look at anatomy. And we use it for like IOL placement for UGG. We often find a haptic in a bad spot for like these UGG syndrome patients. We can go around looking for retained lens fragments. We often get a better idea by inspecting posterior, like we've talked about doing like angle closure patients or iris plateau patients. You can actually see the position firsthand of the ciliary process. So it's endoscopic, so we can see what we're doing versus transscleral cyclophotocoagulation, which is a blind procedure based on what we know. So we can decrease aqueous production and do it under direct visualization. I think that's one of the attractive things is there's visual feedback when we do this procedure. So it's very self-guided, and it's cool.
I don't know if that video is going to play there, but I think a video will probably show it nicely, and the data will hopefully support it as well. But yeah, one of the values I think of endoscopic surgery is basically be able to see and titrate what we're doing. So I don't know, Gok, do you want to talk through that video before we get into?
Okay, so this is the probe.
I'm in the way. I'm going to stand over here for a second.
Like so you have 2 probes, either a straight probe or a curved probe. Personally, I prefer the curved probe. It gives a bit more ergonomics, and you can get a bit more treatment area. You enter through a corneal incision, similar to a phaco. 2.2 would be fine. You don't have to combine it with a phaco. So it should be done in a pseudophakic eye to have space in the sulcus, but it can be done as a standalone procedure. And as I said, you make your clear corneal incisions. You inflate the sulcus space with a viscoelastic to make sure that you're well away from the posterior iris pigment, because you don't want to induce extra inflammation. So you're inflating that space. So take out the OVD from the bag, so you've got a nice space to view the ciliary processes. So you've got the straight probe or the curved probe. People will have certain preferences. And this is what we talked about. You've got the image in the middle, you've got the light, and then below that the laser. And this really is, you start at the base of the ciliary processes and you slowly work your way up. you want to see both a shrinking and a whitening of the ciliary processes. So I always sort of teach my fellows, if you think of Karate Kid, wax on, wax off. You've really got to take your time and not just move on to the next one. So you've really got to start from the base and work your way up. So you see that shrinking, but not to treat the posterior iris there. And that also rotates the ciliary body posteriorly, which Robert alluded to. Gives you, particularly in plateau patients, can create more space in the anterior chamber and open up the angles further. It's not a difficult treatment, but you have to get used to not looking through your microscope and looking through the screen. So you're sort of looking in that direction. I think the muscle memory can take a few cases, but once you've done a few cases, it's very straightforward surgery, I think. So.
Great. Yeah, we'll speak more about, picking the right patients, as well as a bit of technique modifications, and also some of the certain special cases and risks and associations with that. So thanks for showing that video. I thought that's helpful. I think that one of the questions we always ask ourselves, we're kind of in the era of MIGS, right? MIGS is taken hold as an important glaucoma procedure we often use. MIGS we kind of define as typically patients or procedures that are, ab interno, that are microincisional, that are ultimately much safer than traditional surgeries. Typically we think of outflow procedures. We think of like trabecular meshwork procedures. We think of perhaps suprachoroidal procedures. I don't really consider bleb procedures in that group, but basically outflow procedures. So, maybe I think an important discussion point was, where does ECP fit? Do you consider ECP to be in that category? Can we consider it MIGS or not? To be honest with you, ECP has been around prior to MIGS, actually. But, in the era of MIGS, which has kind of opened up more discussion about early intervention, where does ECP fit in this whole category, if it does fit in the category of glaucoma procedures?
Yeah, I think that's a key question and a big question. I think it can be used as a standalone procedure for sure. It's a deviceless procedure, so you're not leaving a device in the eye. That may fit with some people's views or concerns. At the same time, and it's the only MIGS surgery that addresses the outflow, whereas everything else is about, the production rather than the outflow. So for me, I do it as a standalone procedure occasionally, but more often I combine it with an outflow procedure. For me, it's that sort of turning down the taps and improving the drainage from the bath. So, got my thing hanging down.
It's kind of like using a prostaglandin and a beta blocker, right? One drop increases outflow, while another drop reduces inflow, right? And so I guess that's perhaps the best analogy. Where do you see this? How do you classify this? Where do you see it with other options we have in glaucoma today?
So I think exactly to your point. So I think more and more we're kind of, just as we do with medical therapy, is we combine more and more with outflow procedures. So, most of the MIGS procedures, goniotomies, canal-based procedures, the stents, those are limited by, the downstream anatomy. So there's some eyes that maybe the system is just shot. There's a problem with the episcleral venous level, and you can do the best canaloplasty, but it's just not going to lower the pressure that much because there's too much disease downstream. So a lot of times now we're doing this in combination. So as you said, some people, a PGA doesn't work. The outflow stuff doesn't work. So you can go to this instead of or in combination with. And I think we started doing it early on in the game with eye stents. We did this ICE procedure where we did ECP combined with the eye stents. And we still do that some. But the nice thing about ECP, I always say this, is you really can use it any place in the glaucoma surgical treatment algorithm. You can use it in those mild patients. The most common place it's performed is in combination with cataract surgery, because I don't like it to perform in phakic patients. There's just not quite enough working space. So I always try to have the patient pseudophakic or aphakic. Then you have a lot of space. So cataract surgery is certainly an easy place to do it, because you take out the lens, then there's all the space in the world to access the ciliary processes, because you have to be able to see them to treat them. But then, you can do it for moderate disease where other MIGS procedures have failed. You can come back. I have patients I've retreated 3 or 4 times, so it's retreatable. And then we have kind of the ECP plus population where everything else has failed, tubes, and we can come back and do it from a posterior approach and really knock the pressure down that way. So it's very versatile, and it's just nice to have an option that works differently than everything else, because sometimes we exhaust the minimally invasive outflow procedures.
What about technique-wise, Gok? I mean, how difficult is it? What's the learning curve? You work with trainees as well. I mean, how difficult is this to do? I know a lot of procedures we do, for example, MIGS, they're not easy. We're tilting the microscope, we're using gonial lenses, we're working in the angle, gonioscopy, visualization. I mean, how difficult is it? How does it compare to other procedures?
Yeah, I think there is a learning curve. I think the biggest learning curve is looking away from the microscope that we've got so used to looking at. I know with heads-up displays now, we're getting more and more accustomed. But I think it's that ability to look away, and the movements are different to suturing or phaco, where it's sort of repetitive. So there is a muscle memory that comes along. Trainees, fellows, new users do get frustrated because they're so good at what they normally do, but it's a very quick learning curve. I think in terms of the amount of treatment, which sort of goes to that, I sort of rarely do a 360 treatment now. I think with the curve probe, between my main incision, phaco incision, and my side port, I think I can get around to around 270, even 300. And when I looked at my data between 270, 300 treatments versus 360, I didn't see any extra pressure reduction. So to create the extra opposite clear corneal incision, I've sort of moved away from that personally.
So, I mean, I'm sure some of you here are thinking transscleral cyclodiode, even cyclocryotherapy, where you're freezing the outer part of the eye to reduce aqueous production. I mean, that's what we think about.
You're dating yourself.
Well, I'm looking over to you actually when I'm saying that. And that's still being done though. I mean, people still use transscleral. We have like painful blind eyes where you're doing this, right? So, I mean, I think we got to deal with the elephant in the room, right? I mean, most of us in glaucoma don't like to use those destructive procedures earlier in treatment.
The word diode has a stigma. Sure, yeah.
Sure, right? And you just mentioned earlier that you're using it in earlier disease. And so I mean, how can you address that? Because, I mean, I think it's a real question.
I think it's good.
I mean, we're photocoagulating. We're treating the ciliary body, which we use externally. So, I mean, what about that issue? I mean, and how and why is this different?
So I think you bring up some really good points. So there's treating and then there's over-treating, okay? So part of it's driven by technology. So once again, going back to your cryo example, I mean, it's a blind procedure. You're basically whacking a good clock hour every time you freeze it, right? And then you get coagulative necrosis in everything in that treatment zone, and then that cascade of events keeps going, and that's why half those eyes end up with hypotony, blah, 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 ptysis. I mean, so it's relatively uncontrolled. Then we have the transscleral, the continuous wave, which was more focused, just mostly in the ciliary body, and a lower amount of overall energy, but it's still, you could get coagulative necrosis. And then transscleral, we've gone to micropulse, which once again tries to get rid of the heating element, and that's more benign, so you don't have as much kind of thermal penetration. And that goes back to ECP. The nice thing is we can see what we're doing. So if you beam that thing in there, and the ciliary process, as we saw in the videos, turns white and shrinks, and if you keep going, it blows up. That's bad. So that's that's on the surgeon. So if you get popping and destruction of tissue, that's gonna be an inflamed eye. If you learn, just like we learned angle surgery or cataract surgery, that you learn where to get it white enough, and where you basically just have treated the ciliary epithelium, and then you stop and move on, or you just move on. I think so. That's both. It's technology, but technique.
If you ask any surgeon here, would you want to do a surgery blind or be able to see what you're doing? Everyone here, without doubt, is going to say they want to see. And, no two patients are the same. Some patients, you have to really hold that laser on for a bit more time to get that melanin absorption. Other patients, you're turning the power down. So that's what you don't see with the transscleral, what's going on. Right. That's why you see multiple pops with some patients. So it's just having that safety of knowing you're treating the same amount on each patient with a direct visualization. I think that's the key thing, right? You're not guessing. And that's why you're not getting hypotony. In some cases, you do transscleral, you get no response. And then you crank up second time round, and then you get too much response. So it's that safety element which is key, really.
Yeah.
Yeah, and I'd like to give simple examples so Rob can follow me a little bit.
Speak slowly. You're going a little too fast for me so far.
It's like, for example, in glaucoma, we talk about doing outflow procedures, right? Trabeculectomy is an outflow procedure. it's a pretty aggressive one. Most of you will not do it for somebody with mild glaucoma or early glaucoma. But so is trabecular outflow procedures like goniotomy or iStent or other procedures. They're both outflow procedures, but they do outflow very differently. And I think addressing inflow is also, there's extreme with transscleral approaches, and then there's ECP. So they both maybe accomplish similar things, but in a very different and more controlled way for ECP. So I think that's an example I give. Is everyone following us pretty well now? Are we kind of grounded in what ECP is, right? So maybe let's get into talking about.
Do you know what ECP is like?
Well, we're gonna unveil the new definition soon, right? Let's talk about then the role with combining a glaucoma procedure with cataract. Because in the U.S., like, I think it's becoming more common, although there's still many people who aren't doing it. But around the world, it's still not a very common concept to combine a glaucoma procedure with cataract, especially when it's not trabeculectomy.
Yeah.
So, what are your thoughts about, like, what's the value in combining a glaucoma procedure with a cataract? I'm not talking about trabeculectomy. I'm talking about like someone with mild to moderate disease. They're on medications. They're not getting worse, but they're on medications. Their glaucoma is mild to moderate. I mean, what's the reason why you explain to your patients why it's worthwhile to do a procedure? Let me talk about ECP specifically.
Yeah. Okay. So yeah, I think the key thing is we're not talking about bleb procedures. Phaco-bleb is a whole different, kettle of fish. But, sort of the ab interno MIGS surgeries, and particularly ECP, you want to go into a patient's eye as few times as possible, right? Every time you go into the eye, you have risks of endophthalmitis, you have surgical costs, patient costs. So it's about trying to maximize your surgery. So, if you have a patient where the cataract is the main issue, adding a few extra minutes to the surgery to address the glaucoma, which may be well controlled, but you have a chance to reduce their drop burden, or the glaucoma may also be uncontrolled and you have a chance to control the disease. So for me, it's about trying to do as much as you can in one sitting without compromising the outcome of the cataract surgery. Patients want to see well. Even the glaucoma patient, they want to see well that next day. They want to wake up and see 20/20/6/6. So, you've got to try and find that right balance there. But certainly what we are looking at more with longer term data is, are we preventing disease progression? Are we preventing patients going to have filtering surgery? Are we preserving visual fields? Because patients are living longer as well. So for me, trying to combine makes sense.
Yeah, I mean, Rob, are there patients who have glaucoma on medications that you would not consider combining? I mean, these days, it's almost the exception in my practice. But
I agree. I don't know why I wouldn't, honestly.
Right.
Because they have glaucoma, it's like, this is the chance. And when I put it to patients, like, people get this these days too. It's like they understand. And sometimes the happiest thing you can do is take them off their glaucoma medications. Like, we're going to make you see better with the cataract part, but also we know cataract surgery can help the eye pressure. But while I'm there, I'm going to do this additional thing to help lower your eye pressure even more, which will make your eye healthier and safer. And maybe we can get you off your eye drops, is the conversation I have. And they're like, oh, that sounds good if I can get off my eye drops because I'm paying $400 a month for whatever. So, I'm hard pressed because I think by definition they have. If I'm treating them, they have glaucoma. Right? If they're on medications, they have glaucoma, and So I can't think of the last time I didn't. The only thing is, like, some insurances we can't because of insurance coverage. But if it's my choice, that's what I'd have on my own eye.
Yeah, no question. Access does limit, usability in many different jurisdictions, of course. And like you, I'm hard-pressed to say, why would I not combine something? You have one time to do it. But the key point for me is it's got to be safe, right? It's got to be a procedure that we don't think is going to impact the recovery of cataract surgery. Yeah. We love cataract surgery. The refractive outcomes are great. Most of us don't want to compromise that. Of course, if the glaucoma is really bad, we're willing to do it. We do a trabeculectomy or a trab. We have to do that because their disease is so bad. But we're talking about that earlier patient. So maybe, again, getting back to what I talked about earlier, but just ECP and the differences. Can you speak to the safety of the procedure? And I'm talking about, like, intraoperatively and also post-op safety and recovery.
Yeah, I think here's a lot of misconception and a lot of variability even in the UK. So people worry, obviously the two things people worry about is inflammation and pressure spikes early on. So intraoperatively, really there's not much that can go wrong. As long as you can hold the probe and direct it, and you're away from the iris, and you're, you can laser through the capsule, but you're not meant to. So as long as you've got that good plane, intraoperatively, you're very stable and it's very safe. I give intracameral dexamethasone, 0.1 mil, intracameral at the end, and I'll give the remainder of the syringe 0.8, 0.9 subconj. So I give a bolus early on just to sort of tackle the inflammation in the first 24 hours. I haven't seen, in hundreds of cases, any case of fibrinous uveitis at day 1 or week 1. I don't routinely give Diamox to patients, but I do check their pressure an hour after the surgery before they go home. And if there is an early rise, I may consider a bit of Diamox for the first couple of days. I am a bit more aggressive in my steroids than just cataract alone. So I give preservative-free dexamethasone every 2 hours for the first week. But really, with that regimen of intracameral, subconj, and Q2 hourly for the first week, when I look at the eyes at week 1, they look as quiet as cataract alone. Maybe that's overkill. I'm not sure what you guys think, or
what do you do?
So I agree with that. So part of it, I think it all goes back to the proper technique. So especially if you touched the iris with the probe or had contact, that's going to be a problem. If you've had a pop, like over treatment, you're going to get inflammation. So those cases are exceptional, and you do have to be very aggressive with. But I think with the newer instrumentation, the new system that BVI is coming out with, the procedure is only getting safer and safer and more straightforward for the surgeon to do. So I think it does come down to surgical technique and just knowing the treatment parameters. But I do the same thing. I often do what I call a Kenalog wash. I'll just put some Kenalog in and rinse it away, and there's residual particles there. I treat inflammation very proactively, so everybody's on an NSAID and a steroid, especially the first week. And then, like I said, if you do that early, you'll be fine. I think IOP spikes often happen because you don't get the viscoelastic out of the eye, because we're putting a lot of viscoelastic behind the iris, and it's easy not to see it, and also it can stick back there. So I think taking an extra 30 seconds to take out the viscoelastic makes a big difference, where I rarely get IOP spikes anymore since I've been extra compulsive.
Yeah, and don't forget, you do cataract surgery in a glaucoma patient, we get IOP spikes.
Yeah.
Mm-hmm.
Anyways, right?
Yeah,
They're just
they
at
all
risk.
spike.
So I think you still got to be mindful of that with whether you do ECP or not.
And I don't stop their glaucoma medications when I do this. I wait till I see them in the office.
Okay. Yeah. And personally, I typically don't inject steroids myself, and I just I typically use like a Predfort or Maxidex QID. Typically, that's my typical course, and I can't say I see really typically much issues. There might be slightly more inflammation, but in certain patients you may want to use it a bit longer. Maybe NSAIDs depending on the patient profile. I think I would say that it's rare to see CME. Mm-hmm. It's rare to see CME in cataract surgery. It's rare to see it with this. But the key, again, as you heard earlier, is a technique, right? I think that we can, under direct visualization, we can titrate the energy. Exactly what we're seeing it all happening in front of us. We can slow things down, speed things up as we need to. And I think most of us, like you and yourself, are probably doing about 270 degrees, right? And
something like that.
Around there. I don't think that there's too much benefit to doing more unless you're going to really go down and do the pars plane and everything else, right? So, it's not something that I think you have to really spend a lot of time, getting every single, and you can't anyways. You never laser every single, ciliary epithelium,
just
right?
the front row, right?
Exactly, yeah. So I think that from that sense, the inflammation aspect is pretty low.
But that brings up an important point. Like with this, if you do it from an anterior procedure approach, you can't get hypotony. Like you just can't access all the ciliary process. There's more posterior. If you come from a pars plana, you can. Yeah. So you don't have to. In some ways, just like other MIGS procedures, you don't have to worry about hypotony as we do with, say, tubes or something like that.
They're two very different procedures. ECP and ECP plus. One is a much more aggressive treatment with a different side effect and post-operative profile and potential risk of hypotony, choroidal detachments. Yes. As you said, anterior in the sulcus, you don't get hypotony.
And so what we're talking about ECP plus is basically lasering the ciliary process, but also going down and lasering over the pars plana as well. So it's a lot more laser involved with that. And that brings up the other point, which is like we talked about the patient population that's earlier, but there's a role for patients who really are at the end of the road. They've had like multiple con surgeries, they've had traps, tubes, and they still are uncontrolled. And now you're basically deciding to do something aggressive. At that point, I think we do have to be more aggressive, though. You do have to do more treatment, and then you're going to potentially have more risks. Just like doing a third tube on somebody, you know. We got sick eyes, other issues, and that's where, yes, we take more risk, but there's also more need in those patients. So it's important to distinguish that patient profile and that technique from, at least from my practice, the more common technique, which is more that earlier case, combining with cataract surgery, combining with MIGS procedures together, which we'll talk about in a second. We want to distinguish those groups. And I think that I don't have any report of anybody in that population in the early cases that's had hypotony. Because people always say, oh my God, I'm making hypotony. I don't see an issue. In fact, I think there's probably more risk with suprachoroidal procedures with hypotony than with ECP.
True.
And still that's low overall, right, you know, in that case. So let's maybe talk about where I think a lot of us are going, which is basically now to add ECP to a trabecular outflow procedure. You know, we have all these options in trabecular outflow procedures, cutting techniques like GAT, dilation techniques like canaloplasty, stenting procedures like iStent and Hydrus. And I must say, I think we're all generally happy that we have these options here. But, you know, why would you or when do you consider to add ECP to one of those MIGS outflow procedures?
Yeah, so for me, I think if it's mainly about the cataract and their glaucoma is well controlled and they're happy on their one drop, then just doing a outflow procedure probably gives them a good chance of being off that drop and giving them very good vision. So it tends to be those that either have a little bit more going towards moderate disease or have a higher IOP or higher drop burden or showing signs of progression. So it tends to be that slightly more aggressive glaucoma patient or that little bit not advanced, but a little bit more going to moderate rather than true mild disease or pre-parametric disease.
Yeah, I mean, so it's interesting. You know, we always talk about MIGS, and it's like it's in some ways the mild to moderate glaucoma patients with cataracts usually, but they're a very heterogeneous group too, right? So I'm going to teach somebody's on 2 or 3 meds, same scenario, have a cataract. This is going to be something I add on to get like lower IOP, where I think like one procedure alone like won't do it. So for instance, you put an iStent in it, you'll knock them maybe down to the upper teens, but maybe you want to press your target pressure is 15 or below. Like this is a way I'll do it. So a lot of times I'll do it for kind of in those combination cases, more moderate. And I often tell surgeons to do what they feel most we all have tools, but you know, there's 6 different ways to do a goniotomy now, or there's a few different ways to do a canal. I think it's good to do what you're comfortable, what you do best is always my advice. So you get good at this, and you get good at one of the stents and good at one of the canal procedures. And I think, you know, when you put your best things, those are for those more difficult patients, because I think we all have them. It's like, I'm going to do this first, but it may not be the conversation I have. This may not be the last thing we do. There's other people, it's like, you're really good. We're just going to optimize you while we do your cataract and hopefully get you off meds. And that may be the end of it in terms of procedures.
Yeah, you can see there's lots of different aspects to deciding what procedure to do. So as you heard, I mean, ECP can be done on its own. It can be done with another MIGS procedure. It can be done on its own with cataract surgery or done with MIGS procedures with cataract surgery. A lot of different combinations on that. Of course, we want to know, like, what do we expect and what are the results? So, I mean, Gok, you've spoken about and you've presented some of your results. Maybe you can just kind of go through this and what your findings are. I'll stand over here so everyone can see through my head. I'm not transparent.
So this is my 2-year data on ICE2. ICE2 because it's 2 iStents. Obviously, when this procedure was first done, it was the first generation of iStent. And really what I wanted to see was between 12 months and 24 months, are we getting a regression to the mean? We know we got good iStent long-term data, but is the ECP effect wearing off? And what's encouraging is really when you go from 12 months to 24, you're still getting a good pressure reduction, starting off an average of just shy of 20 and still at 13.4. When I first started, I was quite conservative about my drop reduction, but now as I have more confidence in the treatment, I'm more aggressive with my my drop reduction. And these patients are so smooth in the clinic. It's not like trab patients where you're massaging, you're doing a suture lysis, you're doing a needling. You know, these patients come in, you have to see them very rarely. We published the 1-year data in BJO, and what we showed was the 1-week IOP is a really good predictive, has a good positive predictive value of what their 12-month and now they're 24-month IOP. So in terms of your busy clinics, if they're doing well at week 1, day 7, you can really start to say, actually, I'm going to see you in a few months' time. So that also has an important part on our busy clinics. The other thing, which I haven't presented here, but I'll be talking about at another session, is we do a lot of work looking at quality of life. And these patients, now that they're, particularly those that become drop-free, the quality of life in these patients is transformed. You see them week 1 when they walk into the clinic room, they have an extra swagger in their steps, they're no longer, they can see better, they feel more confident. So it's out of the scope of this session here, but getting patients controlled and their anxiety and getting off medications, it also improves their quality of life. But it's encouraging to see. Obviously, I want to look at 3-year data, 5-year data, and with 3-year we can start to bring in the visual field data to sort of say, actually, IOP is just a surrogate of disease. But are we actually controlling their visual fields? The number of these patients, this is probably around 200 patients, the number of these patients that have gone on to have a bleb surgery is also less than 5%. So that's another big thing here. You may be preventing a patient that may have had a bleb surgery in their lifetime. So I guess that's the outcomes in a nutshell. So
yeah, I mean, that's pretty impressive to get pressures down kind of, on that low teen level and see that medication reduction. I mean, 2 medications at 20 it's not a small burden there. So
I should say, and it's probably at about 1.5 to 2 millimeters more than just the iStent by itself. So
yeah, that was the question I was going to ask. I mean, how would it compare to doing it one or the other on its own? And so I think you're kind of getting both benefits here to get that pressure reduction as well. Mm-hmm. What has your experience been, Rob, as far as getting results?
I think these are fairly representative. We did the original ICE study with the original iStent, and we got similar results. And I think that's the motivation why we're seeing more combining of procedures overall. Because, listen, I don't think with MIGS anyone's ever really knocked the improved safety profile like compared to trabeculectomy, which is what we had to do with everybody who needs surgical glaucoma. The safety's always been there. It's the shortcomings have been on the efficacy side. And I think, this is an example of, using this technique where you can really, if you get most patients, 14 or below, like that's going to stabilize. It's very hard to have progression at that level.
That's getting towards bleb territory,
isn't
it?
That's like perfection. It used to be like, hey, you have to have a trabeculectomy. It's the only way we're going to get you there. But this is a viable solution. So I'm impressed. And
well, let's see. Let's hope it continues onwards. So.
Yeah, I mean, and we don't want to disparage trabeculectomy. I mean, as much as we do these things, we still do. He will. Yeah.
I will.
I mean, trabeculectomy has a role, but a bleb irreversibly changes the course of the eye, right?
It's bad.
Mean, you always have that bleb. You always have that risk of infection no matter what.
Putting a giant hole in the eye is bad.
Yeah, so, I mean, it's something that most of us like to kind of push off. There's still a role for it. And that's what the search is for, is to try to find the best treatment or combination of interventional treatments to treat it without creating a bleb, and hopefully as well using it earlier, Okay, one more question, and then I want to make sure we have time for questions from the group here as well. I'm sure there might be some good questions, so arm yourself to ask these guys some tough questions.
They have to wake up to do that. Like.
Yeah, well, I think everyone's awake here, almost. You have to basically buy this box. You got to buy this box. Mm-hmm. You got to buy the fibers, right? It's a little bit different than putting a stent in, for example, or, getting a blade and do something, right?
Yep.
So, I mean, maybe you can speak to this in your practices. How do you justify the value add to that? How does the economics make sense? If you can speak to that a little bit, because that's always a practical question.
So yeah, Ike, as you said, there's that initial financial outlay versus buying a procedure that's cost per unit. But the fiber optic cables, as long as handled carefully and not bent, and because it works through a total internal reflection, you can use these cables several times. I'm not sure, well in excess of a dozen, probably 2 dozen if you look at after it. Yes, the image quality does go down. So after the initial outlay, then the cost of each surgery is essentially nothing, because you got the instruments there. Each Europeans is such a wide variety of how we deliver healthcare. In the UK, the remuneration is good for this procedure. Once combined with phaco, it goes to a different tariff, which is actually an even better remuneration. So certainly my NHS hospital don't have any issues with this. But again, I can't speak from a sort of pan-European perspective. So.
Okay, yeah, helpful.
Yeah, I think I agree. There's a capital cost, but we're in ophthalmology. Like we have capital costs, right? Phaco machines in the office, OCTs, cameras, like, and you do have to make a decision in your practice if you'll use it enough to justify it. But what I find is the more you do it, the more you want to do it. And secondly, I get referrals from all over the world to come and have ECP done. So I think it's one of those things, if it's available, you start finding other uses for it. Like I said, all my UG patients, I use it for that. I go back and I look at the IOL, the misplaced IOL in place. It often solves mysteries. So it's a really useful tool to have. And once again, once it's available, it's not a big deal to start using it. So.
And another thing, as a surgery, it's fun as well, right? You know, so some of these devices are becoming so predictable that it takes some of the fun out of the surgery. But actually, seeing what you're treating is quite rewarding, and it's quite a justifying and quite a rewarding surgery in that way. It's not difficult, but it's nice to see what you're doing to alter the physiology of the eye, and then you see them post-op as well. So whereas with outflow procedures, you're hoping and assuming. Where it's nice, you're actually seeing. I don't know.
Hey, I think the fun factor is always important when you pick a procedure, and I agree. I mean, it's like a capital equipment, like a scope or a phaco equipment that we bring in and use, and the value is in that, and I agree. Okay, well that's great. I just want to make sure we have some time for some questions, and some comments. Anything that we haven't discussed or to clarify? Don't be shy. I can pick on anybody here. Complications, yeah. So we talked a little bit about it. Let's talk about what are the most common complications and what are the most serious complications that you see with ECP?
Most common early on would be IOP spike in the first 24 hours and inflammation, both in the anterior chamber and potential cystoid macular edema. You've got to risk profile your patient like you would do for any surgery. So if you've got a diabetic patient, put them on an NSAID. You know, if a patient has had CMO in the other eye after cataract surgery, then you may have to, think about what the best treatment option is here. Intraoperative complications, honestly, hand on heart, I have not seen one. If you give yourself the good surgical visualization and you have your view, then it's no surgery is 100% safe, but I haven't seen it in hundreds of cases. I think they're the main things that you watch out for. Otherwise, the complications are very similar to cataract surgery, the endophthalmitis, all those other things.
So intraoperatively, I mean, we work with trainees. We see some things. I mean, maybe allude to that. What could you do wrong in the OR that could be complicated?
I think during the procedure, I think the biggest things is not staying away from the iris. So I think it's very important, we saw in that video earlier, to make sure the iris is almost against the cornea if you do it from an anterior approach, because the more space there is, you apply the laser it's easy to apply the laser to the ciliary process. So I think really kind of hyperinflation of that ciliary space is by far the most important thing. If you stay away from the other tissue, because lasering the iris does no good. Doesn't lower pressure and you get inflammation.
And you're usually doing this, phaco's done, you put the IOL in? Or when do you do it?
It depends. So there's two attitudes. One, you want to have the IOL in and it's like, okay, the cataract part's done if you're doing the combined procedures. On the other hand, if you don't put the IOL in, you can laser a lot of ciliary process. You can basically push the bag back. You can see the ciliary processes right through the capsular bag, and you get an excellent treatment if you're comfortable doing that. So and often you can also do it through the bag. You can hyperinflate the capsular bag and do the laser, stick the laser probe in there. So you have excellent access if that's what your mind's. Part of it's psychological. I just want to make sure, okay, the cataract's done. I did a good job with that. Then you do ECP. On the other hand, you can get better access the more, just like aphakic patients. So it's like, wow, there's all kinds of space in here. You can laser anything you want. So I typically don't put the IOL in first, but I think I understand why you would.
Yeah, I agree. I mean, we don't see complications very often. I think probably, the inflammation might be one thing. It's, maybe in a higher risk patient, but sometimes you see that with cataracts. So I don't know if I want to completely blame the ECP for that. That's probably the most common thing, if there's a common thing. And then, if you're using a laser and you're not paying attention, you could go into the zonules or hit the iris. That's, obvious there, of course,
Yeah.
If you're lasering too strongly, you could pop. And you get inflammation more when you get these pops and you get bleeding. That's when you get more inflammation. But otherwise, it's there. Now, I will say other things that if you're too light, and you're too, shy about doing it, then you won't get an effect. I sometimes hear that people, well, I do ECP, I don't get an effect. So you have to do enough to see some anatomical changes, but not just kind of go so fast. You're not lasering enough. So it's a balance that comes with some training.
Yeah.
I think that this is a procedure that you can really do nicely in a lab.
Yeah.
So I recommend you can do it here exactly, and just working these eyes and just get a feel for how your hands are looking over there, and I think that can help to reduce some of those complications. Yeah, good. Important to know that. Good question. Any more questions from the group? We want to make sure we hear a bit more from some of you here. Been hearing us all the last hour, so someone's itching to ask a question. You want to ask a question? No.
There's a lot of excitement here. There's a lot of excitement.
I see someone wants. I see you want to ask a question. Question? Yeah. So I don't want to put anyone in the spot, but But we appreciate coming out and attending this. I think in glaucoma, it's often ignored, and I think thanks to interventional mindsets now, we're looking at being more assertive, more proactive, and I think ECP is part of that area. And whether it's open-angle glaucoma, one thing with ECP, by the way, is it can be used in open-angle glaucoma or angle closure, which is not true for many other MIGS procedures, most of them. None of them are labeled for that, at least. So I do often actually use it for angle closure as well. Not only can it reduce aqueous production, but I like to use it to actually move the ciliary processes back, and a modification of technique to open the angle up. For example, plateau iris. So I think the versatility of it, mild to moderate disease, all the way to really severe disease, open-angle glaucoma, angle closure, and also combined cataract surgery. That's why I like having versatility. All right, we got a hand up here. Yes. You have a mic, or you can just shout it. Here's a mic.
Come on up.
Come on up now.
We can't hear you, but
Can you hear me now? Can you hear me?
I can't. I don't have.
I work with Radhika, so there.
Hi, Gok.
Hey, Radhika.
Hi, Ike. Nice to
Yeah,
meet you
tell
in
the truth
person.
now. Tell the truth about Gok.
I'm not going to
Turn
spill
the mic
beans.
off.
No, my question. Hi, my name is Radhika Rampath. I'm from London, UK. My question is, with the advent of, the progression of, say, machine learning and AI and ophthalmology, why are we not looking at big data of how much, so how much ECP, say for example, okay, I think that 270 degrees will give me this result or this reduction. If you map it out with a big enough, I don't know if you've already looked at this, but if you map out a big enough data of the number of people who have a pressure reduction and say, okay, X amount of degrees gives me this amount of reduction in a particular population, can you not then extrapolate and say, actually in the future, we don't have to guesstimate, let me just do this amount of degrees of ECP. Why not actually say, this amount will give us this amount of reduction, so why don't we do that for the patient?
So it's basically the use of AI. Can AI and deep learning and big data sets help with titratability of ECP treatment? Is that sort of right?
Yeah.
Yeah, I mean, that's so true. I mean, I think with all the cases that are being done, collecting this and understanding how much to treat, where to treat, the degrees, I mean, that all is just ripe for utilizing data to help guide therapy. And that's the excitement about AI. It's not just, of course, for diagnostics, but also in terms of using that data to do that. I think it's going to take some effort to do that. Obviously, we do have some registry data, but that also comes with its own challenges. So I'm excited about big data and AI, but also, we've seen kind of a big interest, and it's kind of like, okay, are we going to be able to really understand it? And then now more interest in it. So I think you're right. I cannot deny that.
Yeah, I mean, when you have data,
the only concern I might have is the each patient variable, the aqueous production. What are we starting with in terms of that individual patient? That's going to be different for. It doesn't change that much amongst a cohort, but a younger patient versus an older patient, a uveitic, so you've got that variable to start with that you might not know to sort of see your treatment effect.
Well, but that's what big data should get, because then you're going to have like thousands of patients who fit that potential profile.
And
but we need enough data though, and you're right that that's the challenge with that. You need enough data, but also broad enough data to cover all the kind of patients we may see.
I mean, if anybody can get data, it's you, Ike. So I think you should start the movement.
We should start the movement. Yeah, I agree. Thanks for that comment. That's very true. We'll get Gok to start on it.
But it's true. At the moment, there's a good amount of published literature out there, but it's all like this, individual centers case reports. There is an RCT being done of FACO versus FACO ECP, led by Sheng Lem at St. Thomas's in London. So RCT data will obviously be great, but compared to the hundreds and thousands of cases that are being done worldwide, pooling that together is a whole different level of big data for sure, yeah.
Great. Well, thank you, Gok, and thank you, Rob, for
Thank you.
sitting up next to me here, keeping me awake, alert.
What could be better than this?
Oh,
Cheers.
yeah. Oh, yeah.
Sitting
Slok-
shoulder to shoulder in
Slokova.
Milan at.
We wrap up? We're just wrapping up. You stole my thunder. Well, we are wrapping up. Thank you so much, everyone, for listening
you.
here and contributing here. Thank you.
Cheers.
Thank you, guys.
Cheers, that's good.